I'm Faith Rogers from DKB Med. This is our first program dedicated solely to monkeypox as part of our new series, Monkeypox Keeping Up with a Moving Target. Thank you so much for joining us. DKB Med has embarked on this education because of the growing concern over monkeypox. As you know, the World Health Organization has declared the monkeypox outbreak a public health emergency of international concern, and the White House has made a similar declaration for the United States. For well over a decade, members of the scientific community have been concerned about the potential of a monkeypox epidemic, and with over 32,000 reported cases worldwide and counting, we are providing this education for you and the patients you care for. This educational program is supported by DKB Med with in-kind support from Partners for Advancing Clinical Education and the Institute for Johns Hopkins Nursing. You will notice several windows on your console here. The resource window should have a copy of today's slides available for download, and you'll also be able to access the evaluation by clicking that Claim Credit button. Your thoughts and comments are important and will help us develop future activities. So let me take a second to introduce our faculty. For those of you who have joined us for the coronavirus series, you will recognize Dr. Auwaerter, the Clinical Director of the Division of Infectious Diseases at Johns Hopkins School of Medicine. He'll be giving us a brief overview of what we know about monkeypox currently. Thank you so much for joining us, Dr. Auwaerter.
Thank you, Faith, and delighted to be here on this important topic.
Okay, so these are the faculty's disclosures. And this activity, like I said, it is supported in kind from DKB Med. All activity content and materials, though, have been developed solely by the planning committee members and the faculty presenters. Our learning objectives today are to describe the clinical presentation and disease course of MPX, and also assess the safety and efficacy of vaccinations and treatments for MPX. Please note that this information is current as of the date of our recording. That's August 11th, 2022. Because we know this is a public health emergency and it is ever changing, please do consult the CDC, World Health Organization, and the IDSA for the most contemporary information on MPX. So before I hand it over to Dr. Auwaerter, we have a few knowledge questions to kick off our webinar. So if you don't see the submit button on these polls, please do scroll down. Sometimes it can get cut off on smaller screens. But let's get started with our first pre-test question. Pre-test question 1, monkeypox or MPX is not transmitted through which of these? Contaminated clothing or bedding, respiratory droplets, bodily fluids, or aerosolization? Okay. Our next question here. Data suggests that the average incubation period for MPX is that 1 to 5 days, 3 to 10 days, 7 to 14 days, or none of the above? Okay. And our final question here. Common presenting symptoms prior to rash that occur in some patients include fever and abdominal pain, cough with hemoptysis, myalgia and malaise, or none of the above? Give you just a moment to answer that. As a matter of fact, while you are answering this, I'm actually going to hand it off to Dr. Auwaerter to kick us off. So Dr. Auwaerter, thank you so much.
Thank you, Faith, and thank you so much for joining this program on monkeypox. We're still learning a lot about this virus that has been with us for some time, but not nearly in so many places and countries. In the first part of August, there have been over 30,000 cases identified. And as with any reportable disease, this no doubt is an undercount. And over 80 countries have reported having monkeypox that have never previously had cases. And this virus, to give you a picture now, really is present in most parts of the globe and likely will affect many more people, and the prospects of bringing this under control such that it might only be limited to a handful of countries, I think at least in the short term, is unlikely. Now, here in the United States, cases have been growing since late spring, and we have over 10,000 cases, with the states reporting the highest number in those with major metropolitan areas. And perhaps with no surprise, it's on both coasts, also Texas and Illinois. So this was first identified in May in terms of at least a new occurrence of monkeypox outside of its historically endemic areas. And the first United States case also was in mid-May. Now, it took more than 2 months and a growing number of cases before the World Health Organization issued a public health emergency, quickly followed upon by the 2 states with the largest numbers in the US, namely New York and California, and then Illinois. And then a public health emergency at the time of this recording was done less than 2 weeks ago, which has greatly facilitated the abilities of agencies and funders to help with this outbreak. So just by quick background, for those of you that may not be as familiar, this is a zoonotic virus, first identified quite a while ago in Denmark, but the first human case was identified in what is now called the Democratic Republic of Congo. And there have been outbreaks since that time, often in more rural villages. And generally, those smaller clusters have been identified and have thought not to have led to any kind of a significant large-scale outbreaks. And what was known from monkeypox cases over the past 40 plus years are that it does require close contact, very similar to what had been the experience with smallpox, which of course plagued human populations for millennia. But that large respiratory droplets could convey this, and this was especially true for children that suffered from this. But much like any of the pox viruses, it's a hardy DNA virus that can at least remain viable on fomites such as bedding and clothing and so on that could potentially facilitate. Now, the current impact of this outbreak we'll speak about, but has been mostly in social networks, gay, bisexual men and other men who have sex with men, which is thought to have been mostly by intimate skin and mucous membrane contact. So this is something that I think we'll continue to learn more about, and there may be a more sense of whether there's some respiratory transmission, just like it was in the early aspects of the COVID pandemic. People are often being more conservative in both PPE and isolation than perhaps need be. I just want to briefly comment that since the first case in 1970, there have been periodic cases all centered in either the DRC or other countries of West Africa. But you can see the numbers were not particularly large, except for in the DRC. But in more recent years, those numbers have grown substantially, including in the Congo, but also in Nigeria. And the mortality rates often affected children and ranged from anywhere from 1% to 10%. But the current outbreak appears very genetically related to what has been identified in Nigeria since 5 years ago. And the thought is there may have been many more cases than being recorded in Nigeria. And there have been some physicians in Nigeria who had felt that this was not as widely addressed as it ought to have been. Now, what do you need to know about monkeypox? Well, it's an infection which When acquired, will take on average a week or two to develop first symptoms. And there's nothing of a set pattern. Some people will have flu-like symptoms, including fever, before a rash. Others will just have a rash only. And others will have the symptoms develop simultaneously. They can include some aspects where you might think it's an upper respiratory tract infection, like sore throat. And then the rash itself, some people may first notice something, especially if they don't feel ill. They might just think it's a pimple, a blemish, a macule, not a traditional pox mark. I have some early lesions here. And then these are some pictures of more advanced lesions with more classical pox-like vesicles and pustules that develop, that can disseminate and often affect the hands. Unlike the West African and African experiences of monkeypox, we tend not to see this affecting the face first, but rather wherever the contact occurred. So this may often be in the current outbreak in the genital or anogenital regions. There was a recent New England Journal review, which I think is always very helpful to put together as an early educational effort. And I think some of the take-home points that I took from this is, of course, here's someone that has tonsillar exudates. It's not strep throat. It's not even gonorrhea or infectious mononucleosis. This was monkeypox with exudates. And then if you look at this rash at day 3, you might think, oh, that looks like scarlet fever. Or it might look like even the measles. But indeed, they will evolve and turn into those that have a bit more of a vesicular pustular perspective. And at least PCR evidence of infection was still present through 2 weeks. That does not mean people are still infectious through that time. We're just still trying to understand that. But they were not able to detect a positive PCR at 3 weeks. So as already mentioned, this current global outbreak has a very low mortality, lower than what's seen historically with monkeypox, and no deaths have been recorded in the US, with only scattered reports in other countries. Besides the viral infection, you can get secondary bacterial infection, just as if, for example, chickenpox can be complicated by cellulitis. Bronchopneumonia, sepsis have been described. There have been rare bouts of encephalitis or involvement of vision. People that are ill may have some leukocytosis or thrombocytopenia, even some increased LFTs, and potentially more ill people with low albumin. And the people at risk for severe disease historically have been people that are on the younger age of the spectrum, so children, anyone with atopy, eczema, skin disorders, anyone that's immunocompromised, and also people with HIV, especially if CD4 counts seem to be below 350. Now, there's a growing amount of information on what's occurring with the global outbreak, and some of the take-home points from the early U.S. experience. Here you can see it's almost mainly men, although there have been some women and children thought to be from household contacts who have been affected. You can see the age is on the younger side at 35. Most have reported intimate contact with men preceding, and about 40% with HIV. And rash was uniform, but could be anywhere, as you can see, but genitals were predominant with other systemic features in most, but not all. Now, a more recent global experience was published as part of that review paper I just mentioned, the New England Journal. And again, the current outbreak has been men who have sex with men. Again, 40% with HIV, almost identical age globally at 38. Almost all people with a rash, although I'll mention there are a growing number of preprints that have talked about asymptomatic monkeypox virus upon screening in sexual health clinics. So we may not truly understand how many people might harbor the virus unknowingly yet. But this particular one, I think it's important to point out that 3/4 had anogenital lesions, 40% mucosal, probably reflective of intimacy and sexual practices. And very few had only something that might look like a syphilitic ulcer or HSV with a single ulcer. Again, many had systemic features of illness, including adenopathy or headache. And the median incubation period did fall within a week. Now, and here, the hospitalizations often were for pain management, especially for proctitis, but there have been also a handful of other complications, as you've seen here. And at least the early experience, because there hasn't been wide availability of antivirals, has been 5%. But in these over 500 cases, there has been no deaths. Lastly, the London experience out of Guy's in St. Thomas Hospital, sort of in the central London area, had about 200 cases, very similar, as you can see here, in distribution to what's been mentioned. However, many people here, the rates of systemic illness were higher, and 2/3 of people had those prodromal symptoms before the findings of rash or oral ulcers. About 10% were hospitalized, again, for severe rectal pain, proctitis, and penile swelling. Predominantly my colleague that I know in London haven't been overly impressed with antiviral therapy, but of course, we really don't have careful studies on this at this point. But people have stayed for about a week, as you can see. So this is by no means a problem that is benign. In terms of clinical management, diagnosis is important. You may have high clinical suspicion, but you need to entertain if this could be alternative disease processes. It could be herpes, chicken pox, other pox viruses, potentially STDs, including LGV or syphilis. And most people are using an orthopox screen, sort of broad primers with subsequent confirmation, at least in the United States, by state or CDC health labs. And some academic centers have developed in-house testing, but now Quest, LabCorp, and others do have commercial testing. Isolation is a very frequent issue. So most people have fairly benign disease, luckily. They don't need to be hospitalized. And they mainly need to be counseled to stay at home. And that's until all illness resolves. If they do have respiratory or fever, masks are advised if needing to head out of the house. Avoiding close contact, not sharing items because of what we mentioned. And in terms of when you get out of isolation, the current advice is to wait until fresh skin covers all lesions, and this can take up to 2 to 4 weeks after onset of symptoms. Now, treatment we'll talk about, but not everybody needs treatment, and certainly for those with localized disease that are not particularly ill, they can be observed and often improve on their own without intervention, other than some mild supportive care. The Centers for Disease Control, who controls the current treatment, has really just broken down to 3 groups, and that includes anyone with severe monkeypox. And there's some examples here, but basically anything that's going to buy somebody a hospitalization. And as I've mentioned, most, at least here in our hospital, have been for proctitis. People at elevated risk, those could include the immunosuppressed younger children, anyone with eczema or psoriasis or other skin conditions, and people with HIV, especially with lower CD4 counts. And then, if you do have monkeypox in a particularly difficult place where you cannot swallow, for example, in the eyes, might be considered for treatment. Now, for uncomplicated disease, it's mainly just supportive care and isolation. The predominant antiviral at the moment is an antiviral approved by the FDA based on the animal rule for smallpox called Tecovirimat. There's very limited clinical experience with its use in monkeypox, dating back to 2019 in the UK experience. Sorry, I'm going to redo this slide. The phone rang.
Whenever you're ready.
Mhm. Now, for treatment, for those that have mild disease, it's going to be self-limiting. You may have some supportive care, but the main counseling is for isolation and to help answer questions. The only antiviral in the United States that's widely used at the moment is tecovirimat. This has been FDA approved under the animal rule for smallpox. We really have very limited experience with monkeypox. Case reports from 2019. Of course, we do have some growing experience, but it is not FDA approved for monkeypox, which means that the only way to procure it at the moment is through the Centers for Disease Control. And what they have is something called an an expanded access IND. And this is not an EUA. This is not as though you can just prescribe it. You do have to go through regulatory paperwork, file a form 1572 with the FDA, for example, and submit it to the CDC. And I've given you the webpage there for those of you that may not have worked with your state and local health departments to have a supply on hand where you can get oral or intravenous antiviral, generally within a day of submitting the required paperwork. Now, there are some other agents I've listed below. None of those have been really widely used, although they may have activity. Specifically, I mentioned brincidofovir. At least the UK experience, they've not been using that because they really have seen increased liver function tests rather quickly with this drug, and they're not certain of its benefits. Now, vaccines have been a very important issue because we have a FDA-approved vaccine for both smallpox and monkeypox by the trade name of Jynneos, modified vaccinia virus that's live but non-replicating, meaning you can give it to immunocompromised people by 2 subcutaneous injections. And there has been a large stockpile of this in anticipation of a bioterrorism event. However, much of that stockpile is expired. But there's been some recent quick activity here because the ACIP has only recommended it to date for people with occupational or high-risk exposures in adults. But the FDA did issue an EUA after the public health emergency declaration recently that said it could also be used in children. Probably the more important attribute is that intradermal application has been authorized also by EUA. And what this does is take a 0.5 ml application and then essentially dilute it to 0.1 ml and give it intradermally. And I'll show that in a moment. So this is something that I think will be looked at and used to expand that vaccine supply. There is an older vaccine called Dryvax. This is the old live smallpox vaccine. It's 1 dose. It's not being used because, honestly, that vaccine has potential dangers to it. And since this is not a lethal disease, unlike smallpox, I think the current thinking is to not employ that older style vaccine, even though it may have efficacy. We still don't have abundant clinical information about how well Jynneos works. The thought is it might be about 85% efficacious, but we'll have growing information. Now, as I mentioned, the Jynneos is really the vaccine of the day here, and it can be used after exposure within 4 days. But it's really this intradermal administration that I spoke of that's only for adults, not for children, and might be able to expand the supply 5-fold, which should certainly handle higher risk supply needs in the forthcoming months before more vaccine is produced. A 2015 study, which I've cited below, suggested that neutralizing antibodies are generated at a similar level in healthy volunteers compared to the sub-Q administration. There was some more local redness, but not as much pain as with subcutaneous administration. And of course, all this was done in healthy volunteers. I have some pictures there that show you that if you've ever applied a PPD, you sort of know how to raise an intradermal bleb. But requires a little more skill to do efficiently and correctly. So one of the reasons that it may take a little bit to roll out. So in summary, I think one needs to have a high level of suspicion to suspect monkeypox in people that might have unexplained fever or a rash, even if it's not pox-like, and may be worth asking if they have risk factors for acquiring, but also to continue thinking about doing other screening, especially for venereal diseases that might be also present. It does seem milder than historical, which is a good news. We're still trying to understand if the antivirals such as tecovirimat are beneficial. Isolation is critical to help slow the spread, and especially with intradermal use, hopefully the existing supply can be expanded and rolled out to more people, including healthcare providers who may be at risk, for example, handling lab specimens and so on. So Faith, thanks very much. And I think we're at the post-test.
Great. Those were very important and timely updates, Dr. Auwaerter. For our learners, I know we covered a lot of ground today, so I wanted to take a moment to remind you these slides are available to download in that resource window if there's something that you'd like to review again. So we're going to move now into that post-test, but I also invite you to ask any remaining questions that you might have for faculty by submitting them in the Q&A box on your console. Though this webinar is on demand and not live, we are monitoring these questions and might just get to yours during our next webinar. So let's answer those questions that we saw at the beginning of the webinar again. And I'll start with the first one. MPX is not transmitted through which of these? Contaminated clothing or bedding, respiratory droplets, bodily fluids, or aerosolization? Okay, so here's as a reminder what the learners said before. And here's what you said after. So Dr. Auwaerter, what is the correct answer here?
Yeah, Faith, thank you. For our current understanding, the correct answer is D, because we do not think this large pox virus can be spread by aerosolization. Of course, there'll be more information regarding those lines. It's really respiratory droplet and really bodily fluids or skin contact with active lesions that appears to be the main roles of transmission.
Okay, thank you very much. Our next question here, data suggests that the average incubation period for MPX is that 1 to 5 days, 3 to 10 days, 7 to 14 days, or none of the above? Okay, so here's what our learners had to say before, and here's all of your responses after. So Dr. Auwaerter, what was the answer we were looking for here?
Yeah, so as we've learned about this, it tends to be C. People are presenting often within the first and second week after a potential acquisition.
Okay, good to know. Thank you. So this is our final post-test question, and then we will be moving into the Q&A as a final reminder to submit those questions. But common presenting symptoms prior to rash that occur in some patients include, is that fever and abdominal pain, cough with hemoptysis, myalgia and malaise, or none of the above? Okay, so here's what the learners said before, and here's what you had to say after. So, Dr. Auwaerter, what is the correct answer here?
Right. So everyone thinks of monkeypox as a rash illness, but they can have fever. But it's really myalgia and malaise as part of a viral-like prodrome, rather than some of the other answers here, such as coughing up blood or prominent abdominal pain.
Perfect. Okay, and then I'll say that we're going to move into the Q&A. So we polled our learners, so on and so forth. So Dr. Auwaerter, I'm going to start off with our first learner question, which is, do patients who were vaccinated against smallpox in the 1950s or 1960s retain any memory B cells or immunity today against this monkeypox virus? Fantastic. Well, thank you so much for that, and thank you to our learners for participating in that today. We're going to move now into the Q&A. So, Dr. Auwaerter, I'm going to start with the first learner question here. Do patients who were vaccinated against smallpox in the 1950s or 1960s retain any memory B cells or immunity today against the monkeypox virus?
Well, Faith, I think it's important to say that we're not exactly sure, but what has been studied is whether people harbor antibodies, neutralizing antibodies against smallpox. This was particularly studied after the 2001 bioterrorism event. And one study was done in 2008, and they were looking at people in a cohort of 246 patients that were followed longitudinally, looking to see if they had neutralizing antibodies from their smallpox immunization in the United States many years afterwards. And what they found was that there was retention of 3 logs of neutralizing antibody in everyone up to 88 years after their smallpox immunizations. So it seems to me that by analogy, there probably is some protection, but we don't know that for sure. You can see the younger ages of people that are presenting certainly skews under the ages since smallpox immunization stopped in the United States in the early 1970s. But we'll see if we find people that are, in their 50s and older with smallpox. There no doubt will be some, but my sense is there will be some protection, certainly from potentially severe illness.
Okay, here's our next question then. As colleges and schools resume in the fall, is it likely that we will see an increase in monkeypox cases in the community?
Well, this is one of those crystal ball questions, which is not exactly clear at all. I would have to say it depends a bit on whether this virus tends to be most facilitated by very intimate skin-skin contact, for example, and whether it might spread to other populations, which certainly is possible. And of course, in colleges where people live in dorms or in elementary schools where often children are touching one another and playing on the playground and, a little more intimate contact than typically adults employ in their day-to-day lives. It's possible you might see that without knowing. Wrestlers, for example, always had something called herpes gladiatorum, where wrestlers, someone might have had an active herpes lesion, spread herpes. So it's something that we'll have to see if that's indeed the case, but I think it's far too early to tell if this is something we'll just see on occasion or something more widespread.
Okay, good to know. Thank you. Here's another question then. Does this virus survive on surfaces, so the playground, library, commuter trains, and if so, for how long? How does this impact awareness of transmission in public places?
Yeah, this is one of my more frequent patient questions and concerns, like I'm traveling, I'm going to a bar, how concerned should I be? And this is a DNA virus, so it's a bit hardier than the RNA virus of SARS-CoV-2. And like any virus, if you're out of the sunlight, if it's a lower temperature, if there's lower humidity, it will survive longer. Unlike SARS-CoV-2, we see that this likes porous surfaces more than hard surfaces like formica, plastics, and so on. And it can be persisting for a while. But importantly, although we don't yet know for sure against monkeypox, generally disinfectants can handle pox viruses, including bleach and some of the standard antiviral antiseptics. And overall, I'd have to say this is probably low risk. I can't say it's zero risk, but it's probably quite low risk at the moment for people to have any concerns.
Okay, and this learner asks, we are looking to provide testing for our county at our hospital ID clinic. Do we need a negative airflow room? There seems to be some conflicting information about this.
Indeed, I couldn't agree more. So I think a lot has been colored by our early experience with COVID-19, where remember you didn't need to wear masks, then you should wear masks. Was it droplet? Was it aerosol? So I think some institutions, including our hospital, have taken to having negative pressure airflow and using HEPA filters, especially in the hospital where there are potentially vulnerable patients, until we know more. On the other hand, I would say a lot of public health agencies and others are following more standard droplet precautions and universal precautions, of course, wearing gloves and so on. So I think we'll get a better handle on this soon. I think there's a range here, and I personally think we'll probably fall more into the droplet category at worst, but we'll actually need to see. And different institutions are handling things differently.
Okay, our next question and our final question today here is, what is the duration of monkeypox? How long is someone who is infected contagious?
Yeah, the duration of monkeypox seems to be 2 to 4 weeks. Again, the conservative counseling is you should not consider yourself non-infectious until all lesions have fresh skin over them. So even if they look crusted, if they're scabbed over, there's a little eschar, you could still be contagious. So until there's skin, you might be contagious. So we'll know more to see if we can narrow that down. Unfortunately, molecular assessments don't tell you, for example, by PCR, if someone's still contagious. We need to culture the virus. Of course, that's more cumbersome. It'll take a more dedicated study to get at that particular aspect. And of course, isn't 100% itself, because viral culture doesn't necessarily correlate 100% with infectivity. But I think the 2 to 4 week range, and again, clinically determining that someone's skin lesions have all healed, is when you can come out of isolation.
Okay, thank you to Dr. Auwaerter for answering those questions, and thank you to our learners for asking them. So if you're tuning into our webcast today, thank you so much. Please click that claim credit button in the webinar console to attest for credit. Otherwise, please visit us at movingtarget.dkbmed.com. Again, thank you for joining us, and thank you for your dedication to your patients with monkeypox. We will be back with another update in this ongoing series, so do stay tuned for that. Dr. Auwaerter, thank you so much.
Thank you, Faith. And I really want to thank you for participating. Hope you found this useful. And as is the case, this is definitely a moving target. And for your patients and offering the best advice, do try to keep up, and appreciate you doing so. Thank you.